I'd just like to start by acknowledging the traditional owners of the land in which we meet, the Gadigal people. Pay my respects to elders past and present and any Aboriginal people with us today. So Catherine put this up already. There are 8 conditions across leading better value care. I'll touch on them from an ECI perspective and the kind of support that we are providing, but I'm only going to focus on 6 and 7. So the osteoarthritis and the osteoporotic fracture prevention are really around scaling an existing model that has been evaluated well and has shown really positive benefits to both patients and also the system in able, as I think Catherine touched on, being able to manage a surgical wait list in a much better way so that people don't languish on that wait list for a really long time and the right people get the right surgery and the people who don't need surgery are able to move off that wait list. So it's been quite a successful program. So this is about growing it across the state, learning from other sites. And so there's quite a lot of peer support work that happens across those 2 programs. The high-risk foot services, we've mapped across the state high-risk foot services, and we know that the access that people get is really different depending on where you live. And so what we're going to do is work with sites who don't have an existing high-risk foot service, who might just have podiatry in place, to be able to enhance that. It might be through telehealth models, it might be through visiting services, it might be through employing new staff. So the investment in additional activity in that clinic-based service will allow people to grow their service locally and hopefully will mean, and it's probably in the long term, less people coming in through the emergency departments and through into the hospital to requiring amputations. But that's a really long-term strategy because the time it takes to arrest that high-risk foot once it's made it to the clinic is pretty significant. Our focus on diabetes right now is in the inpatient setting. We know that people come into our hospital and are managed poorly when they require insulin. We know there are adverse events. We know that we haven't supported the system well yet to use the subcutaneous insulin chart. So 2 of the things that we're doing, we're building a decision support app to help junior medical officers to make decisions around people who require insulin. So at 3 a.m. in the morning, when you don't quite know what to do, you might not have colleagues around, you can actually log on and get some support in a virtual manner. And the other thing we're doing is an education module that will help support the use of the insulin chart as well. So that will be an online, you can touch in and out of it at any point, but also there'll be some on-site support as well to see whether you can improve the way that diabetes is managed in the hospital setting. Renal supportive care, an existing model again, been in place for 9 years at some sites, for 1 year at other sites, but it's about how can we standardise the way that that's done across the state. So for those of you who don't know what renal supportive care is, it's running palliative care alongside your usual nephrology care. It is not, let me repeat, it is not about stopping dialysis. It's about making the right decision for the patient. So patients who have high symptom burdens may make a choice not to continue their dialysis, but that is about the patient making the choice and not about a system making a choice to do less dialysis. That is absolutely not what renal supportive care is. And then the 2 I'm going to focus on, because they have the same methodology, are around heart failure and COPD. Again, there's an inpatient focus to this work because we know that we thought we knew, and we now know, because we've been in about 30 sites, that there's some variation in the way that care is provided. Falls in Hospital, which has been supported by the Clinical Excellence Commission, is really to look at specifically how can we improve or reduce the rate that people fall with harm in hospital. And with 6 and 7, COPD and heart failure, the prescription practices are telling us that there's a lot to be learned about how can we prevent some of those falls by changing our medication practices. So the definition we use for unwarranted clinical variation, so to repeat Catherine's words as well, there is plenty of clinical variation. there is plenty of warranted clinical variation. The bit that we're trying to determine is what is the variation in the system that cannot be explained by the condition or preference of the patient, and only described by differences in systems. So, you know, if I'm in a rural setting or I'm not in a rural setting, these kinds of things should not shape the care that we can get. So how can we support the system? So our work is underpinned by clinical guidance. So for heart failure, we have a Heart Foundation guideline and the New South Wales Clinical Service Framework. For COPD, we have COPD-X. I don't know whether anyone's seen COPD-X, but it is about a phone book size guideline. So it's very comprehensive. It gets updated very regularly. It's very contemporary. And then underpinning that is both of the conditions, oxygen guidelines done by the TSANZ, and then the quality use of medicines indicators as well, which help us understand what's going right and wrong with our medications use. So the approach that we've taken really has been to understand where there might be some system-wide variation, dig deep into the clinical documentation, and then move into taking control of your own data and understanding what your own data means. So to understand your system-wide variation, we've been looking at administrative data, length of stay, the kinds of data that you routinely see in your hospitals and you have access to. We've also looked at the Bureau of Health Information data because we think that's a flag. So they produce the reports on mortality and readmissions, and so we've been saying, well, you know, in those sites that might have higher than expected mortality, maybe that's where we should focus some of our attention. And again, we use the admitted patient survey data, and we found there's a really good paper published that tells you your readmission risk, and we've been able to map the patient survey data questions to readmission risks, and that helps us to be able to feed back to a site that says 29% of your patients were a readmission risk because of this reason. So we're linking what patients are telling us about their care in the hospital setting to the risk of readmission as well. And then we add in, LHDs tell us all the time, swimming in data, don't know what to do with our data, how can we use it better? So more than happy as a team to be able to bring that into the analysis as well. So when we step to the clinical level, because our EMR can't currently tell us what happens to a patient in terms of an analytics point, and that goes to Catherine's point as well around measure what we should measure, not what we can measure. So we want to push the system to be able to measure what we should measure, but right now we have to do that through clinical documentation audit. So if it wasn't written down or documented, it didn't happen. We used the guidelines that I mentioned earlier, an expert reference group, to develop a care bundle, which then shapes an audit tool for us. They're long audit tools. We think after this first year, we'll be able to cut them down, but we wanted to get a good comprehensive sense of what kind of clinical care was being provided. We do a partnership audit with the LHD. We send out some auditors from ECI, and the LHD provides some auditors as well. They can be JMOs, nurses, coders, and anyone from the team has participated in our audit process. We do 40 files over a winter peak period. And then we do all the analytics, we triangulate it with that system-wide variation for the site, and we bring everyone back into a room and we do a feedback session. And so I'm going to provide you with some of the slides that I've randomised. I've pulled some slides from different sites so that, and all the sites aren't named, but just to give you a sense of the kinds of data that we present and the kinds of conversations we have. Haven't yet been to a site who doesn't say, I think this is our improvement plan. And John, to your point as well, the thing that they always go to is what they're doing wrong. And we like to start that improvement plan discussion with all the things that people are doing really well, because there is some really great practice. And then we want to connect that back to all the other teams that are doing that part poorly, So that's the sort of the value of leveraging off a statewide approach sometimes. And then for you to take control of your own data and work out what that means for you. And in the future, we'll have a system that will allow you to log on, you see your own data benchmarked against the state performance as well, or your peer performers, or some, we're building that right now. So this is just another representation of what I've just described. Really, probably what to sort of add to what I've already described is just that the front end of this had lots and lots of consultation. We spent 6-8 months building this approach, as we knew the Bureau of Health Information were about to release their reports. So we spent a lot of time working out how could we respond. And then I would say that all of this is underpinned by a collaboration. So we have a web portal where people can go and ask questions. You can upload your quality improvement plan. You can go and look at other people's quality improvement plans, and you can really start to get a sense of who's dealing with the same kinds of problems that I'm dealing with. We have workshops, we have monthly webinars that are a mix of clinical, so focusing on the clinical issue, and also focusing on a quality improvement issue as well. And they're open to absolutely anyone. They're on our public-facing website, so you can just log in and join us for those conversations that are of interest. Our next one is on oxygen delivery, and hopefully will help reduce some of the variation we're seeing. Underpinned by all of this, as Catherine mentioned, are monitoring and evaluation plans, with a goal for what you guys come to work every day for, improving patient outcomes and improving experience of both receiving and providing care. We've developed a whole suite of tools to support this. So we have a team of auditors and a couple of audit tools. We're just about to add our diabetes tool to the pack. We've agreed across the system to use generic patient outcome tools. So Promise 29 is what we'll use, and you can add in your disease specific if you want. For the inpatient setting, what we really think is useful is more of the experience focus. The outcome is about a long-term process of care, and so outcome measures are hard to use in the hospital setting. And yeah, as I said, we tailor our implementation support, so depending on what your needs are locally, and we can touch in and out, so we can provide you lots and lots of support through one phase and step back and just be on the end of a phone. So in the last couple of minutes, I just want to step you through some of the data and some of the ways that we've been presenting this data. What I would say is that the thing that we do is, this is not our data. This is not ACI's data. This is the LHD's data. We're just presenting it. So we try to present it as passively as possible and check in with you, because depending on the way that care is practiced and the patient group and all those kinds of things, there may be valid reasons for differences. Here we present the administration route to the hospital. We see a variation in the number of direct admissions through GP referral between sites. And I suppose what we're looking for here is that these people with chronic diseases are often sick for quite a few days before they come to hospital. They're probably presented to their GP. And could we bring them to the hospital a little earlier, before they're as sick as needing to go through an emergency department? So they're the kinds of conversations. Or how can we link with what's available in the general practice in a better way? So this kind of information helps us get a sense. So if you've got no GP admissions, then you've got no link with your general practitioners. But if your GP admissions start to come up, you start to see maybe that you could be linking better back to the community. We also look for whether there's a GP noted in the files as well. And sites go from half patients to almost all patients, so seeing a variation there. Time in ED. This is the way that we present the time in ED. And I have to say, we see a significant variation, and often you're only seeing a small handful of patients who are over the 8-hour mark, but you start to it starts to be a flag when you're seeing 5, 6, 7 patients out of the 40 who might be in that 12-hour plus mark, and we see that at some sites as well. So you're checking in what was going on with the team at that point. You know, was it a winter peak? But I mean, I'm hearing from Catherine that hasn't made a difference. We're looking for whether patients received an ECG in a timely manner and what variation might exist. You might not be able to see this, but the red numbers at the bottom tell you that this was a new admission or a new diagnosis as well. So you can pick out the patients who had new diagnosis from all of our analyses as well really quickly. And we remove the outliers because they tend to sort of make the data really hard to read. Again, chest X-ray, we're looking for how quickly people received a chest X-ray and what were the major results that each of the patients had. This is just a scattered heat map of the kinds of investigations that people received. So we scoured the clinical guidance on what was recommended. We know for the BNP and Pro BNP, that's not a widely used test, and have some robust conversations about whether or not it even should be recommended. But given that it's in the guidance, we put it in there and do measure it as well. But I think it's helping us then shape what recommendations we'll make next year about the kinds of care. And then you can pick out this site had 5 patients out of the 40 die throughout the admission. So you can see, as I said, the red numbers tell you that the patients are a new diagnosis, and then the yellow highlight. So quite rich information, quite a lot of information to absorb. We have about 60 or 70 of these slides, so it's a lot. And then oxygen prescription, it's the area that we see the most variance in, and it's the one that worries me the most, given that the risk of over-oxygenation. So we can see that 13 people saturating above 96% were on oxygen at the first hour after triage, and still by the 4th hour on the admitting ward, we're still seeing a quarter of the patients saturating above 96 on oxygen. And so given the risk, we do have some pretty robust conversations about that, and some pretty concerned clinicians leave that session, definitely. So what have we learnt so far? I'll talk quickly. Sites definitely require tailored support, and that's been a good thing because we've learnt lots about supporting sites in a different way. Oxygen use and prescription is definitely a level of variation. For COPD patients, spirometry testing, so the guideline recommends at least once during an admission, and definitely for a new diagnosis. See very low rates, sometimes in the single digits. Timing of chest X-rays, smoking cessation support, probably more a ward issue, antibiotic use, quite significant variation. So we're working with the Clinical Excellence Commission and their antimicrobial stewardship team to be able to help provide guidance back to teams around what should be used and what shouldn't be used. Key referrals, so referrals back to the community, probably more focused for the ward, and discharge practices. And as I mentioned, this has been a great opportunity to showcase what teams are doing well. I've had at least 3 sites in the last month say they've never been told what they do well. And they go away at least feeling, there are some things that we want to improve, but, I think it's very nice to hear that you're doing things well. These slides will be circulated, and I have 2 slides at the end that are the care bundles that we use. I'm not going to go through them, but I've just put them in for information. So I'm happy to take any questions. That's the end of my... Yeah. Yes, of course. Yeah.
Okay, talk about
we don't have 2 hours, so.
I think it's
it's very interesting because from an emergency point of view, we sometimes feel like live on a different planet.
Yeah.
And I think that when Catherine and yourself are talking about these things, they all directly affect us in terms of every time that patient comes in a little bit less sick, they may be able to go home instead of being admitted. So I think it's very important.
And when at the feedback sessions we have ED in the room, it's a very different conversation. So when you're not in the room, you do more or less get blamed for all of that. If something's going wrong, well, that would be the way that ED practices, or that, But having ED in the room, because we don't always succeed in getting ED into the room. Given particularly lately, it's been much harder. But yeah, it's a different conversation because we can have a conversation about the interface and the impact of what you do on what the ward does, and vice versa. And so I would encourage you, if you are asked to attend one of these feedback sessions, participate, because it makes our work better.
I think that, Catherine, there may have been some data that suggests that the winter surge hasn't affected people, but I think if you look around the empty seats, you can see that it has affected people.
Yeah, and we find it as well.
And some of our speakers as well. It has been a very harsh winter. I was actually away for quite a bit of it in the summer, but I know that people have had one, so I think that surging works for a small period of time, but it has very adverse effects.
Oh, and we haven't gone through the post period of this yet. That we're all running on nothing, and so what happens after this? It's hard, right? So yeah, thanks.
Thank you very much.